All right, welcome everyone to the National Fellows Online Lecture Series presented by the AMSSM and the Fellows Online Education Subcommittee, part of the Education and Fellowship Committees. We're very fortunate today to have our speaker, Dr. Ruikang Leo. He is based in Pleasanton, California, with Stanford UMP, where he serves as faculty for the new Stanford Tri-Valley Family Medicine Residency program that just started in 2025. He did his family medicine residency, or sorry, he did his medical school and pediatric residency at Penn State and Hershey. And I also learned he did undergrad at Hopkins, which is where I'm based. So it's always fun to have these connections. He then did sports medicine fellowship at the University of Colorado, and he continues to practice both outpatient primary care pediatrics as well as sports medicine for all ages. He has been involved with the AMSSM since he was a medical student and has held many roles within the organization, including the pediatric residency representative, the fellowship class representative, and is currently the chair of the special interest group subcommittee. So we're so excited to have you back working with the AMSSM presenting tonight. Just to go over what the goals are for this evening's lecture. So it's not to replace your home program's education, but to act as an adjunct. It also gives fellows access to interacting with AMSSM members and the invited guests that we have, and to help the fellows with their CAQ exam preparation. Um, we have different, usually with these online lectures, we have everyone mute your device, turn your microphone off, turn your video off. This one may be more interactive, so we can see how things are going. And then there will be also time for Q&A, although it's not, this is a little bit different. It's not a topic presentation. It's going to be more a lot of Q&A throughout the program. We do want to hear from you. We want to know if this is a valuable topic, if it's presented well. So give us suggestions on future topics, future speakers, and how you think this lecture went. Here is a QR code that you can scan in order to give us that feedback. And then the other thing that the AMSSM is collecting is a library of sports ultrasound pathology. And so you can use this QR code to access that library, and they're looking for cases to be submitted. And then join the AMSSM Fellows Online Lecture Series next week on a topic looking at mental health and neuropsychology and concussion. And that will be presented by Dr. Chris Bailey, moderated by Dr. Matthew Wise. All right, so now I will stop sharing so that we can get back to the presentation.
It's my pleasure to be your host tonight for this round of Pediatric Sports Medicine Jeopardy. Let's see if that works. There we go. Just got in the mood there. Okay. So if you are brave, you are more than welcome to unmute and also even turn video on to ask questions because, it is Jeopardy style, right? So as I'm actually, just mute that. As I'm introducing the categories, if you don't mind, also, again, if you're brave, go ahead and put in your chat where you're coming from tonight. What's your level of training, like med student versus resident, fellow, just so I can kind of know what my audience is. And if you participate, get more out of it, so we'll have more fun here. But if not, this is okay. I'll be repeating questions for the people that'll be tuning in later as well. I do have my chat open, so I'll be able to see everything in real time. So even if we skip over a question and we moved on, if there's questions that come up, feel free to just throw them in the chat and we'll get right to it. Okay, so here are the categories tonight. First, we have little breaks, big deals. These are pediatric fractures. Attachment issues. So these are issues with the attachment site to bones. You missed what? Well, we hit it here, right? So these are dual miss pathology in pediatrics. Shady findings. So these are just various x-ray stuff. Skin in the game. So dermatology things in sports medicine. Naughty by nature. These are various muscular pathology. And here we go. Do you have any takers for first category? All right, I'm going to start with little breaks, big deals, 200. Here we go. So the Latin word for protuberance or bulge is another name for this common fracture. Let's put it in the chat. Ready for brave, unmute. So anytime we're looking at fractures, I like to look at the cortex of the bones and just kind of trace along it to see if there's anything that shouldn't be there. Now you might look at that and be like, whoa, what is that? Big lines. So those are actually normal growth plates. So don't overcall those. But if I'm looking along here, you see there's just a little bump right there. Very subtle. And if you look at the lateral view here, you see just a little bump here. But you don't actually see an actual obvious fracture line through it. So this is a classic buccal fracture, otherwise known as a torus fracture. And torus is that Latin word part. Okay, so you see this is just a little bend in the bone. Very common pediatric fractures because pediatric bones tend to more bend and buckle rather than just snap all together. Very stable. Oftentimes you could treat this with just a brace for 3 to 4 weeks if they're compliant, or short arm casts, and responds very well. All right. Next category. Do you have any takers? Okay, we'll keep going down this category then. So big or little breaks, big deals for 400. So we got an 11-month-old here and name this common name and the fracture type of this fracture and this young kid who is now refusing to bear weight on his right leg. All right, so first we're looking at the tibia, right? Lower leg and fibula. So we're drawing a line along, just kind of seeing, is the cortex nice and smooth? These are the epiphyses of the distal fibula and tibia, so they're just still developing. These are growth plates. And as we get to the tibial shaft here, you notice there's something here. Okay, you see a shadow. And if you follow it, it almost looks like it kind of turns around like that. Okay, and if you look at the lateral view, you see a line curving around like that as well. And that, with this history, the classic common name for this is a toddler's fracture, which is a spiral fracture of the tibia. So a very common injury seen in kids that just start to walk. They're not very coordinated yet, right? So if you think about your developmental milestones, kids are typically starting to take their first steps independently around 1 year, 12 months or so. And their bones are still immature. So then when they twist and kind of fall on themselves, that in itself, a low energy trauma can actually induce this fracture that twists around. And just a quick review of the different names we use for fractures. So if the fracture line goes straight through the length of the bone, that would be called a transverse fracture. If it twists around, which is from a twisting injury, like the case here, that would be a spiral fracture. Very similar in appearance would be a straight line through without a twisting mechanism, and that would be called an oblique fracture. This is something we would hopefully never see in sports medicine. We're comminuted, and the bone just kind of gets shattered in different areas. Similarly, segmental fracture, where there's actually a piece that comes off. These are more trauma-based. Avulsion fractures are where a bone gets pulled off, usually from an attachment point like a tendon. Green stick fractures are commonly seen in pediatrics as well, where you get a break, but it's only on one part of the cortex, and the other part is actually still intact. And these can actually bend and be angulated. And we have the torus fracture and the buccal fracture where we just saw, where there's no actual fracture line through it, but you do see the bulge in the bone. And then we have impaction fractures as well, where the bone actually gets crushed. So, all righty. Any takers for the next one? Okay, we'll keep going on this category then. So little breaks, big deal, more fractures. And this one, I help you out a little bit. We gave you the positive arrow sign. So name this fracture after an 8-year-old suffered a fall on an outstretched hand. So a Fuchs type injury. Okay. So If you just look at the arrow, you can see the difference between this side and this side. Like this side of the distal radius, very smooth. This side, you see just kind of like a sharp turn in the bone where it kind of goes out like that. And it's even more obvious on a lateral view here where, this side is a little bit more smooth, but this side, again, sharp turn that comes over. This might not look like much, but if you really look closely, you might be able to appreciate a faint dark line that goes in this way, extending towards the growth plate. And then this one, similarly, again, you might see just the faint line that goes this way into the growth plate. Another clue is if you look at the trabecular patterns of the bone, you see all these lines going this way, all the way out. But then when you get to here, it's more fuzzy looking. Okay, so there's actually a fracture that goes through here from the metaphysis all the way into the growth plate. And when we have involvement of the growth plate and the metaphysis, that's classified as a Salter-Harris type 2 fracture of the distal radius. This is commonly confused with actually with even buccal fractures because you notice that little kink and oftentimes it's like, oh, it's just a buckle. But you got to really look closely at the metaphysis into the growth plate to make sure there's no growth plate involvement. You can imagine this. I tell people this is a basically an area of baby bone that's still growing as your body matures. So this is where the bone eventually puts down new bone and grows and gets longer. So if you have an injury to the growth plate, that can actually affect your long-term growth. So these you don't want to miss, and these really should be put in a cast. And just a quick review of the Salter-Harris classification. 5 main types. I really like this mnemonic of just using Salter. So a type 1 is a fracture straight across the growth plate. So oftentimes you won't actually even see a fracture line in the metaphysis or the epiphysis. But this can be either a widening of the growth plate here. It could look actually fairly normal even on x-rays, but when you have a mechanism that correlates and you palpate and it really hurts right over growth plate. A common injury like that is over the distal fibula, basically just after a bad ankle spray. And then we have the type 2s here where you actually see a fracture line that extends into the growth plate and it involves a metaphysis. Another clue, which I really like this diagram, is if you just look at the soft tissue as well, oftentimes you'll see soft tissue swelling around where the fracture is. So that's just something else to pay attention to. And keep in mind, this paradigm, this is essentially a distal tibia. So the epiphysis is pointing down, and that's why the metaphysis is above here. Just remember that and just kind of pay attention to if you think about wrist x-rays, oftentimes we bring it upwards in the sense that the distal metaphysis of the radius will be pointing upwards. So it's not always relative to x-ray. This is just relative to the tibia for this memory cue. Type 3 is basically when you have a fracture through the epiphysis. So this is the other side of the growth plate and it goes into the growth plate here. Oftentimes this will actually extend into the joint itself. And then as we keep going along, it gets even more severe. So a type 4, for the T for 2 parts of the growth plate or through and through. So you have involvement of the epiphysis and the metaphysis. And then finally, type 5, very rare. Some people even debate if it's actually a real thing just because it's so rare, would be erasure of the growth plate. So this is like a crush injury where the growth plate, you don't actually see that space there anymore. It's just gone. So, all right. I need takers for more categories. Again, I am paying attention to the chat, so you're welcome to throw stuff in there or even private message me if you don't want to do it publicly. But we will keep going with little breaks, big deals for 800. So a common name for a trampoline-related injury in a child from doing a double bounce. Okay, again, I showed you the positive arrow sign here. You might appreciate a faint line here around the metaphysis of the proximal tibia here. So this is around the knee area. You actually see maybe a little buckle here as well. So the concept of the double bounce is where if you have 2 people close to each other bouncing on a trampoline, and especially if you have one individual that's a lot heavier, what happens when they jump and bounce down is it's going to push the area of the trampoline just beneath them down. And when that goes downwards, then the area next to it is actually going to go recoil upwards. So then if you have a younger, smaller individual that happens to be there, they can actually take advantage of that recoil to generate even more vertical force. So kids will use this as a way to jump even higher. But that being said, if you are young with immature growing bones that are not very strong, and you have the weight of an adult and the force that they're generating from their body landing onto your tibia, that can put a lot of stress on the bone and cause the tibia to actually fracture through. So this is called a trampoline fracture, which involves typically the proximal tibia metaphysis. It's really an impaction fracture. Classically, this is kids under 6 from the double bounce. And interestingly, if you actually look at safety warnings for trampolines and trampoline parks, oftentimes they should say that kids under 6 are not allowed. But alas, that's why we see these injuries when they're younger than that. These should be casted. Okay. We are going to finish out the little breaks, big deals category for 1,000. So no hints this time, just a picture. But in adolescents, this fracture results from an avulsion of the AITFL and may often require surgery. I meant no positive arrow sign, but that's a hint. Okay, so we're looking along the cortex of the bones, distal tibia. That looks pretty good there. That looks pretty good there. You see the distal fibula and the distal tibia physis there. But then you get to the tibial epiphysis and you see that line there. Now that shouldn't be there. So you basically have a fracture that involves the epiphysis and actually extends into the metaphysis. So if you remember from my talk earlier, this would be classified as a Salter-Harris type 3 fracture of the distal fibula. And this is actually so classic that it has an eponym, which is the Talot fracture. So what happens with this is as your growth plates eventually mature into full adult bone, for the distal tibia, classically the medial part of the growth plate matures first, and then the lateral part takes just a little bit longer. And the AITFL is the anterior inferior tibiofibular ligament. So it connects the tibia and the fibula. These are part of your high ankle ligaments, as opposed to ATFL, the anterior talofibular ligament that's lower down. That's more of your classic ankle sprain. So you can imagine if you have, say, a external rotation force, and this AITFL pulls really hard on this area, and you have a relatively weakened growth plate here compared to the mature adult bone here, this is the path of the weakest link. So you can actually pull off this piece of bone. So these you have to be really careful. Likely you'll actually even get a CT to classify if there's any displacement. And oftentimes these are going to need surgery if there's any sort of displacement. If not, you're looking at a long time of casting this to try to get it to heal. All right, we finished out the fracture category. Do we have any takers for the next one? All right, we are going to keep going with detachment issues. So for 200. So this painful, usually atraumatic condition at the tibial tuberosity commonly occurs in adolescent athletes with anterior knee pain. No arrow sign this time. Got to work for this one. All right, so this is your lateral knee. So lateral knee, you always want to look here over the suprapatellar bursa region to look for an effusion, because you shouldn't have an effusion ever. An effusion is always abnormal, and especially if you have trauma and end up having an effusion, that usually means something tore or something broke. And effusion would be this color, but kind of this area here, and I don't see any. So that's a good start first. And what you see here is the prefemoral fat pad in dark and the suprapatellar fat pad, the triangle here, they should be touching. So that's a really good start. And I did give you the hint of the tibiotuberosity, which is this area. And you can see there are lines here that goes into the tibial growth plate. So anytime you have that growth plate area, it's not as strong as the rest of the mature adult bone. It's a potential area for injury. And when you have a powerful patellar tendon, which is connected to the patella and the quads, all pulling on this area, when you have somebody who's jumping a lot, like basketball athletes, it could actually irritate this area of the growth plate and cause an apophysitis. An apophysis is where the tendon attached to the bone, and apophysitis is when it's irritated. So we have the answer in the chat there. This is the classic Osgood-Schlatter disease, which is apophysitis of the tibial tuberosity. Perfect. So oftentimes this is going to be an overuse injury. So with activity modification, physical therapy, oftentimes that will be enough to take care of this. Very, very rarely do you have to go more aggressive measures. And you might look and say, wait, hold on. There's like a little calcific thing there. Like, is that bad? Did somebody pull off a little piece of bone? And it's really hard to say based on just the image. This is something where you have to just correlate clinically. If this exact same patient, the story was they felt a pop, and now they have trouble extending that knee, this could be actually an avulsed piece. But I touch it atraumatic, so then that's more in line with the Osgood-Schlatter. So this is very there's can be a lot of variation in just how the ossification changes happen in this area. A little bit confusing, but you will see this at some point, either in your clinic or on the exam. All right, moving on. Okay, we got the attachment issues for 400. Gel heel cups may be helpful in this common cause of atraumatic heel pain in active young kids, so they can keep on running. And another hint is this is an eponym. Nice job. What is Seaver's disease, which is apophysitis of the calcaneus? Excellent. Super common. And if you look at the calcaneus, you see the growth plate there, and you're like, wait, hold on, this is like all fragmented. You know, is that an injury? Is that trauma? Is that bilateral calcaneal fractures? Again, you have to correlate clinically. Kids are very interesting. There's a lot of variations in ossification and development. So if this is a kid who's just super active, running a lot, and they have pain in this area, most likely it's Seaver's is super common. But if they actually do give you the history that they maybe fell from a height and they have fractures over the bilateral calcaneus, this is a separate bonus board question, and oftentimes they like to test, is the next place you got to look is going to be in their spine, because that if they're landing like that and injure both calcaneus, the force can actually transmit up their leg into the spine. All right. But this is not that. This is just Seaver's. Oftentimes, gel heel cups, you give them a little cushion and keep on running, but you got to really stretch it out, likely do some PT, and they generally do really well. All righty. Takers for next one. All right, we're doing detachment issues for 600. So a 17-year-old male runner felt a pop at this location with this muscle involved. So I want the site of injury and the muscle. No arrow sign this time. Gotta look. So we're looking at the pelvis. The pelvis is a confusing area. There are many, many different tendons that attach here, and these are powerful muscles that can generate a lot of force. So classically, you look at all these bony contours to see if there's something irregular or something off about them. You want to look at the hip joint as well. And so when you play the game of figuring out what is different, there's a lot of confusing things that can happen with this, you know. So like when I'm looking at that, like, is that femoral head a little bit darker than this side? Maybe, you know, but it is still overall nice and round. So, you know, sometimes you got to correlate clinically, but there's actually a more obvious finding here. So beyond just the contours of the bone, if you look over here, all of a sudden you got another calcific thing here. That shouldn't be there. And that's different than this side. And also, typically you'll have the patient in front of you and they'll point to pain in this area. So, and then you try to have them extend their leg and it hurts a lot in that area. So there's a particular muscle that attaches this area, and this area here is part of the iliac crest. It's anterior, and it's the higher bump as opposed to the inferior bump. So this area here is actually going to be the anterior superior iliac spine, where the sartorius originates. This is often very often confused with the AIIS, the anterior inferior iliac spine, and that's where the rectus femoris attaches. There's a lot of overlapping function in what they do too, so it's super confusing and tricky. Okay, a little memory cue is ASIS, S for sartorius. So both of the S's go higher up, versus AIIS, the rectus, that's the other one. So, all right, good job. Yeah, these ones, it can take a while to heal. Most of them don't need surgery if you take care of it well. But if it's displaced bad enough, it may need surgery. Cool. What's next? Okay, we got detachment issues for 800. Anterior knee pain is common in adolescent, but the three named eponym for this usually atraumatic condition, specifically affecting the inferior pole of the patella, may be hard to remember. You see that irregularity there. And excellent job. Yeah, so this is a hard one. This is the Sinden-Larsen-Johansson syndrome. This is one of those show off your friends conditions. So it's apophysitis of the inferior pole of the patella. So if you look at this, the patellar tendon is here. It connects the patella to the tibial tuberosity where you had the Schlatter. So this is a very similar injury pattern, often overuse. The entire story usually sounds very similar to Roger Schlatter. Maybe they're a little bit older, but on exam, rather than having the most tenderness over the tibial tuberosity, the tenderness is over the inferior pole of the patella. And again, usually it's atraumatic. If you have this exact same X-ray finding, but there's a history of trauma, like they felt a pop and they have trouble extending their knee, then you worry about an avulsion, specifically a patellar sleeve avulsion. And that's a much, it's very different. Some of those may actually even need surgery. Okay, what is next? Awesome. We are finishing up detachment issues for 1,000. So you got a 12-year-old soccer star who plays year-round and has lateral foot pain despite not recalling any obvious injury due to this overused condition. And it's another eponym. So many eponyms in ortho and sports medicine. Ah, this is a tough one. This one is Island's disease. So it's apophysitis. Great job. Yeah, this is apophysitis at the base of the fifth metatarsal. So right there. Okay, you get the peroneal brevis tendon that attaches there, your main everter. It can pull on the area, and somebody who's really active, irritated, just like all the other ones. And test taking tip, anytime you, especially on the sports board, when you hear a young person who does any kind of sport year round, they're probably getting at some sort of overuse injury. Okay. Similarly, exact same scenario, but if they felt a pop and it's more of like an ankle sprain type story, and you see that, and they're mostly tender there, then the exact same story or the exact same look of the x-rays could actually be an avulsion as well. Another thing to keep in mind is the base of the fifth is a very tricky area with many other pathology that can happen. The apophysitis or the avulsions, which almost never need surgery and can be treated non-op, the line of the growth plate is typically inline and parallel to the metatarsal shaft itself. A lot of the other fractures that we worried about, like a Jones fracture, is that the fracture line will be perpendicular to the shaft of the metatarsal. So if you see a line perpendicular, that you want to be a lot more careful. Jones fracture typically should be pinned. All righty, we are a third of the way through. Any takers for the next category? All right, we're going for the big ones. You miss what for 200? The dome misses. Here we go. So this adolescent hip disorder often presents with knee pain and a limp rather than hip pain, often with the leg held in external rotation and restricted hip internal rotation. Obesity is a common risk factor. And we already have the answer in there, Skiffy. Perfect. So this is slipped capital femoral epiphysis. If you look at it, you can see the right side, you have a very well developed, nice and round femoral head. You see the left side is nice and round, but it's not where it's supposed to be. It's kind of slipped off. So this is a don't miss. This needs surgery quickly. All right. What is next? Okay, we are doing you miss what for 400. This pediatric hip condition often causes a limp and limited hip range of motion. And you have to picture that. I didn't even tell you which side, but it did not trick you up anyway. Perfect. Leg calvae perthes. So this is avascular necrosis of the femoral head. And the affected side here is going to be the left side. So this one, compared to the previous one, you can see it's a much younger kid. You have open growth plates in multiple areas. And you do see the femoral head starting to ossify, but you notice on the affected side, it just looks weird. It just looks like it's not developed, as if there's not good blood flow there. So the femoral head never had a chance to fully ossify. This is often confused with Skiffy, and whether it's the sports board or sometimes even residency boards, they like to test this one. So memory cue, if you look at Skiffy again, typically these are older. It's a slip of the cap as opposed to a vascular necrosis of the femoral epiphysis. So it's going to be well more ossified. You might hear the term ice cream falling off the cone. This is commonly associated with obesity. So they're bigger, they're older, as opposed to like perthes. These are going to be younger, and the pictures are going to look younger. And avascular necrosis, they're younger, they're not as well developed. I don't know if that actually helps. This is the way I kind of negotiate in my mind. Usually when they're really young, like under 6 and it's found, they do very well and typically don't need surgery. But if they're a little bit older before it's found, like over 8, sometimes they actually need surgery. So these should follow up with pediatric orthopedics. All right. And we are going 600. You missed what? Here we go. Positive arrow sign. This injury to the subchondral bone can lead to a loose body if not treated. The notch view knee radiographs, often with MRI, can aid in its diagnosis. So you see the line pointing to this little oval lesion here, and you can see the same thing here again. So this is an injury to the subchondral bone. So the cartilage would be here, which you can't really see on the x-rays, but this is the bone actually sub to, underneath, deep to the cartilage. So perfect. This is osteochondral defects or osteochondritis dissecans, OCD. This is a don't miss in pediatrics, especially somebody with chronic pain. You know, many kids will improve even if you don't do anything. Or if you do get them to do some PT, most kids in sports medicine, orthopedics typically just get better with time. But anybody who's not getting better after around like 6 weeks of physical therapy, that'd be kind of weird. And if you haven't gotten x-rays yet, you should probably do that. And the knee at least. And the big thing you're looking for is this OCD. Knee, elbow, talus, these are all pretty common areas. And then for the fellows, the medial femoral condyle, these are the most common area for the OCDs in the knee. Lateral femoral condyle and patella, it can happen there too, but not nearly as common. All right, where are we going next, guys? Okay, you missed what for 800? Clue is this young gymnast presents with low back pain with back extension, which is highly suspicious for an injury at this location. This is a tricky one. So if you're looking at these x-rays, you see these guys and these guys maybe not necessarily line up. So this kid actually has a little bit of scoliosis here. And perfect. I see a concern for spondylolysis and pars interarticularis injury. That's exactly what this is. It's typically a stress fracture. Spondy means spine, lysis, break. So it's a stress fracture of the spine from repeated extension. I purposely made it tricky in that I actually don't see a spondy on these x-rays. But if you have a high index of suspicions for a spondy, even with negative x-rays, you should look further and treat it like a spondy. And pediatrics likely, even though the gold standard is actually a PET-CT, most people will do an MRI because it's a lot less radiation. Um, if you see a high school athlete with extension-based back pain, you should be thinking spondy. It will happen in at least 20 to 30% of that population. So it really should be the number one thing on your differential. So this is one of those where you should have a low threshold for x-rays. And what they love to show you on at least some of the older tests is this oblique type view. And also, this is a picture of an actually like a more obvious spondy. So you see the lucency through the pars interarticularis there. But the oblique view is basically when it's turned, and they like to talk about the Scottish dog look, where if you have a fracture there, you actually see a broken neck for the dog. There's been a nice CHOP study that showed that the oblique views, it basically doubles the radiation, but it doesn't actually improve a whole lot of additional diagnostic utility. So it's really not necessary. Oftentimes, if you don't have a tech that like does this a lot, it's rotated differently, so you just get more radiation without a whole lot of yield. So really, when you're evaluating these kids, lateral view is the most important, but typically one view is no view, right? So AP and lateral lumbar spine, that's typically sufficient as your initial screen. All right. And last but not least, we got you missed what for 1,000? You don't want to miss the small acute fracture at the corner of the growth plate and a long bone in this baby. All right, so you see growth plates here, growth plates here. That shouldn't be there. So this is the metaphysis of the proximal tibia. It's in the corner. This is called a metaphyseal corner fracture. Sometimes also known as a bucket handle tibial metaphyseal fracture. This is a sad one. This has one of the highest specificities for non-accidental trauma. It's often seen in infants under 2 from shaking the infant, and basically that shear force causes microfractures along this immature, still growing proximal tibial metaphysis. So don't miss this one. All righty. We are going to shady findings for 200. On a standing full spine radiograph, this measurement quantifies spinal curvature by drawing lines along the most tilted vertebral end plates and calculating the angle between them. Excellent. What is Cobb angle? Fantastic. So this is how you measure for scoliosis. So as much as I'm sure everybody wants to be perfect, nobody has a perfectly straight spine. You're allowed up to 10 degrees of this Cobb angle and just be classified as spinal asymmetry, which is most of the population. When it's over 10 degrees is when you actually are considered to have scoliosis. And there are some very nice scoliosis talks and spine talks in previous talks. I won't really go into that. All right, shady findings for 400. Gave the positive arrow sign. So on pediatric elbow x-rays, the visualization of this sign indicates interarticular effusion, usually from a fracture. Brush in it, yep, sale sign, also known as the fat pad sign. So what happens is you have these fat pads anterior and posterior to this area of the elbow. And when you have a fracture and bleeding occurs, it actually pushes that fat pad outward. So you're seeing the fat pad like that, which kind of looks like the sail of a sailboat. And so again, here, so the dark, that's your fat pad. The blood is actually here, but because in these views, the elbow, the color of the blood and the soft tissue, it just kind of all merges together. So it's really hard to see. So this is in contrast to the lateral knee and ankle x-rays, where an effusion is way more obvious, and you actually see the effusion as more of this whiter color, as opposed to elbow. The classic sign for an effusion is actually more of this darker color, and because it's the fat pad and not it's an indirect sign of the effusion. So if you see that in a trauma setting, that's a fracture until proven otherwise, and in pediatrics, especially supracondylar fractures. All right, over halfway through. Great job, guys. Now we are going to shady findings for 600. So this radiographic line is drawn along the superior aspect of the femoral neck on pelvis x-ray. The femoral head should cross it, and failure to do so suggests slipped capital femoral epiphysis. So you see this line here along the femoral neck, and you see it bisects the femoral epiphysis, whereas this line, it does not. So it's a clue that the cap has slipped. So this is called a Klein line. All righty, and we're gonna keep moving along for shady findings for 800. So on lateral elbow radiograph, this line drawn along the anterior cortex of the distal humerus should pass through the capitellum. Failure to do so indicates worse alignment in a supracondylar fracture, which will warrant surgery. So you see the line along the humerus here, and that circular thing here, that's your capitellum. So this ossification center here. So A would be normal, where it bisects the middle third of it. This is the great position. C is not subtle, where you see the fracture line here, and the capitellum is way out here, so we are completely not aligned. So this is a type 3 supracondylar fracture where it's very unstable. And everything in between would be a type 2. And this is where if the interhumeral line, which is what this is, bisects part of the capitellum, some of these actually does not need surgery and it can be just casted. So this is one of those things where it's actually named pretty well. It's just the line drawn anterior. It's drawn along the anterior part of the humeral shaft, and it's called an interhumeral line. So important concept to keep in mind. All right, last but not least, we got shady findings for 1000. This acronym lists the 6 elbow ossification centers and their order of appearance, which can be used to estimate age in children due to their characteristic times of appearance. What is Creto? So Creto, there's 6 ossification centers of the elbow. You got the capitellum, you got the radial head, you got the I for internal or medial epicondyle, then T for trochlea, O for olecranon, better seen here on the lateral, and then E for lateral epicondyle. This is really interesting in that typically the capitellum starts to ossify, meaning you start to see it on x-rays around 1 year of life. And then each subsequent ossification center typically starts ossifying about every 2 years. So for example, if you think about Creto, so the next one is R, the radial head typically ossifies around 3, the medial epicondyle typically around 5, and then so on and so forth. So how you utilize this, if you look at the olecranon ossification center here, like, doesn't that look like an avulsion fracture potentially, right? Potentially you could say, oh, maybe that was attached to that and that pulled off. So on the one hand, it's important to correlate clinically, right? But if you think about the way Crito is spelled, so 1, 2, or 1, 3, 5, 7, 9, 11. So the olecranon ossification center typically should ossify around 9 years of life. So if you see these x-rays on, say, a 10-year-old, 11-year-old, that would be probably normal. But if you see this on a 3-year-old, where they're way too young to be expected to have the ossification center, the Lachlan ossification center form yet, that would be kind of weird. So you should be highly suspicious for a true injury there. Similarly, this lateral epicondyle area is very prone to injury. And if you just look at that in isolation, that could be a fracture. But if there are, say, 11, 12, and they're not actually hurting there, and their mechanism completely doesn't make sense for a lateral elbow injury, it's probably just ossification center. So that's how you apply that. Okay, last third. And we're going skin in the game for 200. So this circular lesion on the body commonly presents with a raised border and central clearing, as shown. Okay, what is tinea corporis? Tinea. So this is pretty classic if you're especially taking care of wrestlers. So whether you are going to be caring for these athletes in the high school setting or collegiate setting, there are very well-defined rules about these infectious skin conditions and how to treat it, how long to treat it for before they're allowed to return to play. So just be aware that there are well-documented forms out there, really well done papers and previous AMSSM talks on these topics as well. But classically for tinea, or topical treatment for at least 72 hours. If it's like on the body, but if it's on the scalp, whereas tinea capitis, you actually need 14 days. Yeah, so very common issue there. All right, we're going skin in the game for 400. This intensely itchy rash can show up anywhere, but shown here is a classic spot. To see maybe some tracks, we call them burrows. So this would be scabies. So this is one where topical treatment, you need just 24 hours of treatment before being allowed to return to play. Same as if you had head lice, just 24 hours. However, if you're by NCAA rules, you want a negative scabies prep at the time of competition as well. All right, skin in the game for 600. So name the causative agent and the condition for this often painful contagious infection. All right, what is herpes gladiatorum caused by HSV? Typically HSV1, but it could be 2 as well. So this one you need oral antivirals. And this one is kind of nuanced. So it depends on if it's the first time they're having a flare or if it's a recurrence. If they have systemic symptoms, like fevers and things like that, there's different timing of how long to treat it for. Generally, at least 5 days. Or sorry, for them to return back to sports, if it's the first time, often 10 days, especially if there's no systemic symptoms. If it's recurrence, sometimes 5 days is enough. And there's actually some differences between high school and NCAA level. So NCAA, often they're okay with just 5 days or 120 hours of treatment for first times for return play. So generally 5 days for everything except for if it's high school rules, first time flare, you need 10 days and no systemic symptoms. All right, skin in the game, 800. Help! These lesions didn't look like this before. I think they popped. Okay, what is bolus impetigo? So this is one where a lot of times we think about the classic impetigo around the nose. So those can be just treated topically. But when it's like this, these one need oral antibiotics. So you often Keflex or Augmentin. From a return to wrestling standpoint, you need the oral antibiotics to be on board for typically 72 hours before they're allowed to go back. And all the lesions should be scabbed over. There shouldn't be any oozing or discharge. And also, ideally, there shouldn't be any new lesions popping up over the last preceding 48 hours as well. Alrighty, and skin in the game for 1,000. Okay, we got our daily double as well. Here we go. So don't mind my fever and body rash. I'm just curious what these white spots are in my mouth. What is Koplik spots? This is measles. Sometimes you hear the classic C's, the severe cough, coryza, which is runny nose, conjunctivitis, and Koplik spots, even though it's okay. You can get this rash. Oftentimes, the rash starts like 3 to 5 days in to the illness, and then the high fevers come back. So unfortunately, we got to think about this again. There are some measles outbreaks, due to unvaccination. So just keep that in mind. Hopefully, you never see it. All right, last category, naughty by nature. So muscle issues. Here we go. The sudden involuntary muscle contraction can occur with muscle fatigue or electrolyte imbalance. Uh, what is muscle cramp? Don't overthink it. So forceful stretching of the affected muscle usually resolves it. And you could try to prevent it with regular stretching, adequate hydration, and replenishing electrolytes, especially if endurance athletes. All right, we're going 400. Hyperirritable areas within taut bands of skeletal muscle can produce regional pain within the muscle, fascia, or surrounding soft tissue due to this common condition. Nice, got one for trigger points, aka myofascial pain syndrome. Excellent, super common condition. You see NPs too. And we're going 600. This condition features heterotopic bone formation within a muscle, often after an injury in young athletes, and can mimic a soft tissue tumor on imaging. What is myositis ossificans? So oftentimes these can be treated conservatively. Sometimes they may actually even need surgery. All right, 800. So trigger points of this muscle commonly contributes to pain just distal to it in the anteromedial knee. We're asking for a specific muscle now and the referred pain pattern. Okay, so this is the vastus medialis or vastus medialis obliquus, the VMO. So if you look at the VMO and part of the quads, X marks the spot of where these tight bands typically happens. So these are where the actual trigger points are. And the red here is the referred pain pattern. So if you have medial knee pain, anterior knee pain, especially if you're not seeing any other obvious causes, like you have, this chronic knee pain is not getting better, MRI is negative, think about these trigger points along the VMO. And oftentimes you could do a trigger point injection, needle that area, and their knee pain goes away here. So there are many other muscles that also refer pain to this area too, but they're a little bit farther up, like gracilis, sartorius, rectifemoris. So being the question stem said just distal to it, this will be the best answer. All right, last question here, naughty by nature for 1,000. So knots in this muscle commonly contributes to pain in the heel. So this is also a tricky one. So soleus is probably the best answer. Because if you look at where the soleus muscle is, there's multiple spots where it can have trigger points, and these are referred pain patterns. So it really gives you a significant coverage of the heel. That being said, you also have the posterior tibialis here, which can be even more proximal. That also can get your trigger points or myofascial pain going down to the Achilles region. And then one of my favorites, your gastrocs. The medial and lateral gastrocs has trigger points all over here, and it can refer pain over the posterior knee or even down to the plantar area of the foot. Okay, and we actually have one more final Jeopardy as well. So where are all the locations, trigger points of the trapezius can refer pain to? All right, we're just gonna skip to it because we're running a long time. So you got the upper back, the periscapular region, the neck, temples, jaw, and lateral arm. So I show you here. So if you're getting trigger points here of the traps, you can refer pain all throughout the head here. So many people actually say their headaches are improved after you take care of this. So this is super common, especially in our generation. Everybody's looking at the phone all day and computer all day with a humpback, and a lot of pressure can build up in these areas. And you can even get pain that radiates down the arm as well. Cool. That's all I got, guys. Um, Happy to stay on if anybody has any questions or anything else you guys want to talk about.
Thank you so much. That was very helpful. Great overview of common peds conditions and things not to miss for sure. Um, when you do trigger point injections for kids, are you using just lidocaine? Are you just dry needling them, or what are you usually doing? Or I guess it depends maybe on the age too, a little bit.
Yeah, great question. My typical concoction is D5W and lidocaine. So dextrose, 5% water. We get a whole bag of 50 cc's of it. I drop 5 mLs of 1% lidocaine, squirt that into the bag. So then we essentially get like a 9-to-1 ratio. So D5W has a lot of pain relieving effects, and the lidocaine also just kind of numbs it up a little bit. So I tell people it's basically just kind of hitting the reset button on some of the sensitive pain fibers in the area and these knots. We get these muscles that's chronically been tense and just maybe spasming and force it to relax essentially with the needling itself, which is actually really the most important part. And then the lidocaine is just a little extra to block the nerve fibers there. The volume from the fluid also can release additional tension, cause some bleeding in there to bring more healing factors in there. And then the D5W is just sugar water, so it makes nerves and muscles happy and just kind of helps rehydrate the area and keep it relaxed for longer. Um, no kids like needles in general. Like it's hard enough to get kids to do vaccines in general, right? So it's one of those things where it's really for if the basic stuff aren't getting better, the common sense things, physical therapy, activity modification. But many cases of chronic pain, like MRI negative joints, and you're not seeing any other obvious causes, it's definitely something that I go to.
Thank you.
Yeah. But like if you ask probably 10 sports docs, you'll probably get 12 different answers. Like, there are many people that use ropivacaine, some people only use lidocaine. There's different thoughts about those, but cool. Other questions? All right. That's fun, guys. Enjoy the rest of your night.
Thank you so much.